Welcome. In this explainer, we're going to dissect the core mechanisms of drugs that act on the cardiovascular system and even beyond. The goal here is to get a really deep, nuts and bolts understanding of how these powerful agents work, all the way from the cellular pathways right up to what happens in the clinic. So here's our game plan. We're going to move through 5 key areas. We'll kick things off with the blood vessels themselves and the drugs that control their tone. Then we'll zoom in on the heart's pumping action and contractility. After that, we'll explore the world of agents that manage blood clots and lipids, and we'll wrap up with a crucial look at some key drugs in bone and thyroid health. Okay, first up, let's explore how drugs can manipulate vasodilation, which is just the fancy term for the widening of our blood vessels. This is such a fundamental process, and if you really want to understand blood pressure control, this is where it all starts. Before we even get to the drugs, we have to understand how our body does this naturally, and it's a really elegant cascade. It all begins when our own nitric oxide, or NO, which is made by an enzyme called eNOS in our blood vessel lining, drifts into the smooth muscle. That single event triggers this whole 5-step domino effect, and the end result is the muscle just relaxes. Now, just as important as the on switch is the off switch, and in this case, it's an enzyme called PDE5, which comes in and breaks down cGMP, stopping the signal cold. Okay, so here we have 2 completely different strategies to get to the same endpoint, vasodilation. On one hand, you've got organic nitrates like GTN. They basically just give the body a boost of what it already uses. They're NO donors. They tend to work more on the veins, which reduces the filling pressure of the heart. We call that preload. On the other hand, you have calcium channel blockers. They take a totally different tack. They stop the muscle contraction signal from even starting by blocking calcium from getting into the cell. These guys work more on arteries, reducing the resistance the heart has to pump against, and we call that afterload. But, and this is a big but, with nitrates, there's a huge clinical issue you have to know about: tolerance. Use them continuously and they just stop working as well. There are 3 reasons for this. First, you run out of the sulfhydryl groups needed to activate the drug. Second, the enzyme that does the activation, ALDH2, gets tired and inactivates. And third, the body fights back with its own hormones. This is precisely why that 8-hour nitrate-free period every day is so essential. All right, let's talk about the ROS system. This table perfectly contrasts ACE inhibitors and ARBs. And the million-dollar question always comes down to that side effect, the cough. Here's what's happening. ACE inhibitors block the enzyme that makes angiotensin II, but that same enzyme also gets rid of a substance called bradykinin. So when you block the enzyme, bradykinin builds up, and that's what causes that nagging, dry cough in about 10 to 15% of people. ARBs are cleverer. They just skip the enzyme and go straight to blocking the receptor. No effect on bradykinin means no cough. It's why they're the go-to if someone can't handle an ACE inhibitor. And I cannot stress this safety point enough: never use an ACE inhibitor and an ARB together. That dual blockade is a recipe for dangerously high potassium and kidney failure. It's an absolute contraindication. Okay, so we've covered the pipes. Now let's talk about the pump, the heart itself. We're going to see how drugs can actually increase its force of contraction, a property we call positive inotropy. Digoxin. This one is a classic, and its mechanism is like a perfect little Rube Goldberg machine inside a cell. It all starts when digoxin blocks the sodium-potassium pump. That's step 1. So what happens? Sodium starts to pile up inside the cell. Now, that excess sodium messes with a different pump, the sodium-calcium exchanger, making it harder for that pump to get calcium out of the cell. That's step 2. So the end result? You've got more calcium hanging around inside, which means the next heartbeat is going to be stronger. Simple as that. And that's not all. Digoxin also increases vagal tone, which slows the heart down. That's an incredibly useful trick for managing conditions like atrial fibrillation. But here's the catch with digoxin. It is a dangerous drug. It has what we call a narrow therapeutic index, which means the line between a helpful dose and a harmful one is razor thin. And the biggest thing that can push you over that line is low potassium, or hypokalemia. Here's why. Potassium and digoxin are literally competing for the exact same parking spot on that sodium pump. If you have less potassium around, it's way easier for digoxin to bind and cause toxic effects. That's why you have to be so careful when a patient is also on a loop diuretic, which makes you lose potassium. And remember, other common heart drugs like verapamil, quinidine, and amiodarone will also crank up digoxin levels, pushing you closer to danger. So what if you want the heart to pump harder, but you also want to relax the blood vessels at the same time? Well, that's where inodilators come in. Milrinone works by blocking the PDE3 enzyme, which leads to a buildup of something called cyclic AMP, or CAMP. More CAMP means more contractility and more vasodilation. Levosimendan, though, is really elegant. It makes the heart muscle more sensitive to the calcium that's already there. This is a huge deal because it means you get a stronger heartbeat without jacking up calcium levels, which can increase oxygen demand and the risk of arrhythmias. It's not about adding more fuel, it's about making the engine more efficient with the fuel it has. Just for context, other drugs like dobutamine also work through CAMP, but they're really only for emergencies. Okay, time to change gears. We're moving into the absolutely critical area of hemostasis. We're going to talk about how we can therapeutically stop blood clots from forming in the first place and what we do to bust them up when they're already there. First things first, you have got to know the difference between these three classes. They are not interchangeable. Think of it like this. Antiplatelets are like traffic cops stopping the first few cars from piling up. Anticoagulants stop the road crew from coming in and pouring concrete over the pileup to make it permanent. And thrombolytics? They're the dynamite crew you call in to blow up the whole concrete mess after it's already set. Let's start with the traffic cops, the antiplatelets. Aspirin is the old classic, and its mechanism is just brilliant. See, platelets are basically just little cell fragments with no nucleus. So when aspirin comes in and irreversibly knocks out their COX-1 enzyme, that's it. The enzyme is gone for good for the entire 7 to 10 day lifespan of that platelet. Drugs like clopidogrel and ticagrelor hit a different target, the PGY12 receptor. You'll often see these used together with aspirin in what's called dual antiplatelet therapy, or DAPT, especially after something like a heart attack. Now for warfarin, another old-school drug with a really sneaky mechanism. Warfarin doesn't attack the clotting factors directly. No, it's way more clever than that. It sabotages the supply chain. You see, the body needs active vitamin K to build clotting factors. In the process, vitamin K gets used up and becomes inactive. But an enzyme called VKORC1 is there to recycle it. Warfarin's masterstroke is that it blocks that recycling plant. So the liver runs out of the raw materials it needs to make new working clotting factors. This is also why it takes 3 or 4 days to really kick in. You're basically waiting for the body's existing inventory of clotting factors to run out. So this table highlights a really crucial modern comparison. Heparin works indirectly. It basically finds our body's own natural anticoagulant, antithrombin 3, and gives it a massive shot of adrenaline, supercharging its effect. DOACs, on the other hand, are direct. They don't need a middleman, they go straight for the clotting factors and inhibit them. DOACs are definitely more convenient. Fixed dose, no monitoring. But heparin still has its place, especially in patients with really bad kidney failure. And you absolutely must know about heparin's biggest, scariest risk. A bizarre, paradoxical condition called heparin-induced thrombocytopenia, or HIT, where the drug that's supposed to prevent clots actually causes them. All right, let's move on to another giant of cardiovascular medicine, cholesterol. We're going to talk about the drugs that are, without a doubt, a cornerstone of how we prevent heart attacks and strokes in the modern era. So, when it comes to lowering bad cholesterol, or LDL, the whole name of the game is to get more LDL receptors on the surface of your liver cells. Think of them as little grappling hooks that snatch LDL right out of your bloodstream. Now, statins and the newer PCSK9 inhibitors both get you more grappling hooks, but they do it from completely opposite ends. Statins block the main enzyme that makes cholesterol. This tricks the liver into thinking there's a shortage, so it says, okay, we need to build more LDL receptors to grab more from the blood. PCSK9 inhibitors, on the other hand, stop the destruction of the receptors you already have, so they stick around on the surface longer, doing their job. It's a perfect 1-2 punch. One drug boosts production, the other prevents destruction. And just a quick note, it's really important to remember that statins can cause a dose-related muscle pain called myopathy. Statins are definitely the headliners, but we have other players on the team. Ezetimibe works as a gatekeeper right in your gut, literally blocking cholesterol from being absorbed. Fibrates are the specialists you call when the main problem is really high triglycerides. And bile acid sequestrants are pretty interesting. They act like a sponge for bile acids in your intestine. This forces your liver to pull cholesterol from your blood to make more bile acids, which indirectly lowers your cholesterol levels. All right, for our final section, we're taking a slight turn, but it's all deeply connected to the body's overall regulation. We're going to dive into the pharmacology of bone and the thyroid. These are incredibly powerful endocrine systems, and the drugs we use to target them are just as fascinating. When you're treating osteoporosis, a common strategy is to stop bone from being broken down. These are our anti-resorptive drugs. And once again, we have 2 very different ways to do it. Bisphosphonates are basically a poison pill for osteoclasts, which are the cells that chew up bone. The drug gets into the bone, the osteoclast eats it, and it triggers cell death. Denosumab is more of a precision strike. It's an antibody that blocks rank L, which is the key signal that tells the body to even make osteoclasts in the first place. No signal, no bone-chewing cells. It's also important to note that both of these drug classes carry a small but serious risk of a condition called osteonecrosis of the jaw, or ONJ. Now, this has to be one of the coolest paradoxes in all of pharmacology. Let's talk about teriparatide. It's a fragment of parathyroid hormone, and here's the crazy part. It's all about the timing. If you give it in a short, sharp pulse, like a once-daily injection, it actually tells your body to build bone. It's an anabolic drug. But in a disease state where that same hormone is just floating around at high levels all the time, it does the exact opposite. It tells the body to destroy bone. We're basically hijacking this brief anabolic window. This makes it a really powerful tool for severe osteoporosis, but it's also why its use is limited to a maximum of 24 months. And to wrap everything up, let's touch on the thyroid. For an overactive thyroid, we use drugs like carbimazole. Their mechanism is pretty straightforward. They block the main enzyme that the thyroid needs to produce its hormones. One of them, PTU, has a little extra trick, also blocking the conversion of T4 to the more active T3 hormone. But look, while the mechanism is neat, if you remember one single thing about these drugs, it has to be this safety warning: agranulocytosis. It's a rare but potentially fatal and catastrophic drop in your white blood cells. This means any patient taking these drugs must be told if you get a sore throat, if you get a fever, you call a doctor immediately for an urgent blood test. No excuses, no waiting. So when you just step back and look at everything we've covered, from the intricate dance of ions that creates a single heartbeat to the slow decade-long life cycle of a single bone cell, it's pretty incredible. We've seen how these drugs act like tiny molecular keys, capable of unlocking, blocking, and fine-tuning our deepest biological processes. And that really leaves us with a final big-picture question to chew on. Where exactly is the boundary between a therapeutic intervention and a fundamental re-engineering of what it means to be human?